Hi. Thanks for having me again. We've got a lot that we're going to cover because I always want to do more than what I've got time for, so I'm not going to spend a lot of time on my credentials other to say that I am a clinical musculoskeletal specialist and I've worked a lot with cardiac interventionists because you guys hurt yourself. That is my website and my contact information, and I've indicated to the group that my presentation can be available afterwards for you. So, low back pain. Low back pain is a shared experience. Over 80% of the people in this room will experience acute low back pain. It is so common that one of my clients used to use it as a pickup line. He used to go into a bar and see someone he fancied, and he'd go up to her and say, "Do you have any problem with your back?" And I'd always know who he was dating because he would send them to me for treatment. So it worked far better than anything else that he tried. So what predicts low back pain? A previous episode of low back pain. If you filled out your insurance form, they always ask you whether or not you have low back pain because actuarians know this. There is a 78% recurrence rate. So as soon as you've got it, they slap a rider on your back. The good news is there's a 95% recovery rate. Unfortunately for healthcare professionals, that often means you ignore it. And I'm going to tell you why not to. So since last year, I've developed an acronym. I've got a blog now on this. I call it War on Back Pain. I like it because war is a metaphor, but I also like it because it's an acronym for the 3 stages of back pain. The first stage is warning, and we're going to talk a lot about warning today. Second stage is attack. That's what gets all the attention because it hurts. And the third one is recovery. I've divided recovery into 3 R's. I've stolen the 3 R's of recycling and turned them into resolution, robust, and resilience. What I find is people make mistakes. So resolution is what's getting a lot of the attention right now. It's when a back is coming out of the nociceptive stage, the one that hurts a lot. And in the resolution, it typically has a directional preference. It likes to flex, it likes to extend, but what does everyone do? They do their core. And if you do core in the resolution stage, you better do core with a directional preference. Core really comes into the second stage, which is making you more robust and getting the muscles coordination back. And then we finish with resilience, which is where I want my patients to be, which is when they blow it and they do something like lift a refrigerator backwards up the stairs, and they come in, and my clients do this, and they come in and say, "I hurt my back." I'll go, "No kidding." Then I'll ask them, "How long did it take you to recover?" And if they say 3 days, I'll say, "Get out of here. Life doesn't get any better than that." Because we can all hurt ourselves, but as long as we recover, that is normal. So that's my goal for people, is to get people to the resilient stage. And that's preventing the chronic and recurrent. So the attack stage, the back is relatively simple. It really only has about 4 things that go wrong with it commonly. 1, you bulge a disc. 2, you might herniate a disc, you can irritate your facet, or you can pinch a nerve. And usually it's one of those 4. And again, those will get better. You have a 95% chance that within 3 months, the pain from this goes better. So why is that a problem? Because you then ignore it and you repeatedly traumatize your back. And the problem with repeated trauma is Wolff's Law. Wolff's Law is bone conforms to the stresses placed on it. And what does bone do when you put repeated stress on it? It grows. So what do? We get stenosis. So when I get someone in their 20s, 30s, 40s with a disc herniation or back pain, my thought is I want to see them at 80 on the street, out walking all their friends, and I want them to get off the cruise ships and go into port as opposed to sit and play cards. Because what stenosis takes away from you as you get older is the ability to walk and stand. Now, fortunately, we have a surgery for that, but I prefer my people don't need surgery. So stenosis is not inevitable. You have to put strain on bones to make them grow. If you're not putting abnormal strains on bones, because we can have good growth, which is preventing osteoporosis. So in this picture, who has spinal stenosis? Guy on the left or the guy on the right? The guy on the left, right? And besides his spine posture, what's the other thing that gives away that he has spinal stenosis? What's the cardinal sign of spinal stenosis? A walker. So The longitudinal study out of Japan showed that the sacral slope, the angle between the L5 and the S1 vertebrae, is one of the things that most will predict whether or not you will go into a nursing home and need help with common everyday things like dressing. So I love that study because I'm obsessed with posture, and hopefully it gets your attention to think, oh, that's not the retirement I want. The guy on the right is 90. He is at his 90th birthday. That is his 18-month-old great-grandchild. And the things that are amazing in this picture is, number one, he is standing. You don't see a lot of 90-year-olds standing for their photo, let alone carrying a 35-pound child and looking pretty effortless at it. That's my dad. Those are my genetics, so I'm hoping that's where I'm going. He walked a mile a day for right to the end of his life at age 94, and he hurt his back landing in Italy in the campaign in World War II. So, not inevitable. So I went into Eric's lab a year ago, and we looked at warnings, and that's what we're going to look at. And when I look at warnings, I go to analysis of risk, and then I do biomechanics, and then I look at something called muscle coordination. And muscle coordination is the most interesting research, as far as I'm concerned, that's happening in back pain. I'm going to leave you with 2 videos that we're not going to go over on activation strategies to get yourself ready for your procedures, and one on finding neck posture because we don't have time to go over that. I'm also going to leave you with a resource of a risk analysis grid and a core back and neck tool that's sort of sweeping the back care world as far as guidance. So first of all, why do we injure? We injure when force exceeds capacity. However, is the number one cause of low back pain trauma? No. What the number one cause of low back pain is unidentifiable. My lawyers hate this when they ask me to come to court and predict on something. Back pain is unpredictable. It's usually repetitive and sustained stresses. Identified is much more rare. So how do we learn to reduce injury? By learning to reduce the repetitive strain stresses. So the stresses on your facets, your discs, your muscles. So I've got a picture of Roger Federer up here, and besides the fact he's got amazing Grand Slam recovery, and he's very handsome, so that's also enjoyable. What is it about Roger Federer that might have made me pick him for this slide?
That's mechanics.
Great mechanics, which result in what? Lowest injury rate in men's tennis. Okay? He hurts himself playing with his kids. He does not hurt himself on the tennis court. So by learning to work effortlessly, and none of us are going to play tennis like that, but hopefully we can be that good in our day jobs. So we can reduce injury by knowing when to make change and how to make change. We know when to make change when you're having warnings. So pain or prodromal symptoms, make a change. Analyzing risk, and I'm going to give you a risk analysis tool. How to make changes, biomechanics, and physiology and muscle coordination. So I'm going to give you some tools for those. So one of my other acronyms, MDF. For those of you who are do-it-yourselfers, that means something completely different to you. To me, it means magnitude, duration, and frequency. So when I go into a company or go in with an individual and I'm going to analyze what they're at risk for, I use this risk analysis grid. So in the cardiac cath lab, I went, and it's now filled in for you guys, so you don't have to do this. And where you see the red, mainly in duration and frequency, is where you have your risks. Off in the right is your symptoms. So the first thing I often do is, do you hurt somewhere? I'm going to think about that first, and then I am going to go into your where you've got your highest risk, and I'm going to make those changes first because we're not going to be perfect. We don't have time for perfect. We don't need perfect. So your magnitude, your lead apron, it's heavy. Your duration, you guys do prolonged standing, prolonged bending forward, sustained reaching and twisting. You're at the computer screen a lot, and you have repeated as well as sustained bending forward. Your challenges are patient location and your x-ray location. When I went into Eric's lab, the first thing I did is put my foot right where the x-ray beam would be. So it makes it a bit of a challenge because you want to stay out of that. So my order for change always is I first think biomechanics, which is basically physics. Then I think physiology and motor coordination. Physiology is more what you guys do. And then I'm like, you can't correct all of that. Maybe it's because you're weak. And then I go into the body and look at strength. But I don't start there. So we're going to do a little bit of an exercise on rate of perceived exertion. So last year I had the Maple Leafs up. This year, of course, I have to have the Raptors up. Well done. So your goal in everyday life is to have your rate of perceived exertion of less than 4. Now, some people use a 20-point RPE. I find my clients relate more to a 10-point RPE, and you can use either. So the 4 is on the 10-point RPE. So we're going to look at your two most common challenges, which is sustained standing, bending forward. So I would like everyone to pull out, you've been given this as a handout, standing forward lean, hopefully it's on the top. And you're now going to stand with me. Okay, so come stand up. And you're going to rate your rate of perceived exertion on 3 different standing strategies, all of which you could use in your Cath lab. Okay, so the first one is I call the ski jump, and if you know Eddie the Eagle, whether it's you watched it originally or whether you've watched his biopic, it is basically the standing, and you are going to forward lean, not bend, keep your heels down, feet side by each, lean forward, and on a scale of 1 to 10, you're going to write down how hard do you think that is. And then we're going to do it 2 other ways. And don't think about it too much because you don't have to get the right answer. It's all relative to what you feel. So as soon as you've got a number, put it on the first column, and what do you rate your RPE on that scale 1 to 10 for effort?
Feet shoulder length or together?
Hip distance apart. Yeah, that's closer to shoulder. Good. Better.
I'm just trying to get it right.
Okay, yeah, exactly. I know you guys, that's it. So that's in your first one. Feet side by side, lean forward, scale of 10, write that down. Now we're going to do the same thing, but instead of leaning, you're going to bend forward a little bit more. It's like getting over your patient, right? And you're going to feel that that's a different level of effort than it was when you kept your back a little straighter.
How much bend?
Well, if your patient's that low, I would change them. Okay? Just starting to lean over about a 45-degree angle. Okay? And write that down. Okay. Now I'd like you to put 1 foot forward, what we call stride stance. You're just going to start to just lean forward, not bend, lean. And again, feel the amount of effort. Because now you're going to rate them, and we're going to use pull everywhere. And you are going to put down which one you found easiest. Still see a few typings. All right, starting to look more stable. Which one's easiest?
What's easiest?
Yeah. Yeah.
Crawling?
Going back to evolution, right, exactly. All right, so I think most people have put it down, and on the whole is the 1 foot forward, which is what it should be. So your body over your base of support, which by widening your base of support, should always be easier than when you start to lever your body out in front of your support. If you like architecture, you really should have a fine buttress right now as you do that. And you guys can have a flying buttress. You can sometimes lean against your table in that situation. But the one that makes it a little bit easier is the 1 foot forward. Okay. We'll move off of the pole everywhere. Good. Okay, just a sec here. Good. All right, so my point is, you can have a seat again, small changes make a difference with repetitive and sustained stresses. So something as simple as changing your foot position can change the strain on your back. So when I went to the Cath lab, I definitely preferred the 2-piece apron to the 1-piece apron.
That looks like my apron. It is.
It might have been, okay. Other things that you might be able to do is position the table height close to your center of mass. You may also be able to set up your patient on the ipsilateral side versus the contralateral. I gather sometimes you can't do that, but when you can do that, do that. You can straighten up frequently. What happens is we get bending forward and we just hold it. When you don't need to be bending forward, straighten your body out, come out of the position. And use the lean against the support, of course, as long as the table isn't going to roll away from you. You can also use the wider base of support, and you can keep your torso in line with the activity. So again, I tried that, and what I found was I actually put my foot in the x-ray beam, so then I had to put it forward. But what happens when you do forward is you twist, right? You do this, and you got to get yourself in line with the patient. And if you've read about back care, never do you twist in back care, right? Well, bunk. Life is twisting. Okay? How does someone play tennis, golf, baseball, or basketball without twisting? Okay? You've got to be able to twist. So what you want to do is choose the right muscles to twist. So we're going to do that now. Pull everywhere again. Come stand up again. So everyone is going to twist to the right. You are going to turn to the right. And now you're going to focus on something you never focus on or seldom, is do you lead with your right shoulder backwards or do you lead with your left shoulder forward? And feel where the lead comes from. And then I want you to mark that down on your pole everywhere. Do you lead with the right shoulder back or the left shoulder forward, or you can't decide, so you put down both?
This is turning to your left, right?
Turning to your right. So you're turning to the right. Do you lead with your right shoulder back or your left shoulder forward? Okay. Most people are in? Well, I gotta say, this group did way better than last year.
There's most of them in here already.
Ah, okay. So it is about, just a sec here. No, you did actually worse than last year. Sorry, it's reversed. You should have led with your left shoulder forward. Okay? Why do I want you to lead with your left shoulder forward? Hopefully we can go off the pole everywhere. Yeah. Is twisting is about the oblique abdominals. It is not about the rhomboids. So if you can use a big muscle, use a big muscle. If you have to use a small muscle, you have fatigue more. So rotation is about the obliques. Okay? So if you have to turn, think about leading with the back shoulder forward, and you'll feel your obliques come in. Okay? And that's where it should be. All right, you can have a seat again. If you're still having back pain despite adjusting your biomechanics and improving your ergonomics, you can also reduce your physiological demand with better muscle coordination. And as I said, this to me is where the most interesting current research is. So we're going to do one last exercise. You are going to do the forward lean against the ski jump, and you're just going to rate one thing at this, and that is which muscle's working the hardest, okay? So stand up one last time. You're going to do the first one, which is the Eddie the Eagle one. So you keep your heels grounded, you start to lean forward, and I want you to feel, what do you use to hold yourself up? and what's working the hardest. So you have a choice of using your buttocks, the back of your thighs, your hamstrings, your quads, your calves, your shins and feet, your back muscles, your abs, and you're going to pick which one's working the hardest. And now we're going to put it on poll everywhere, and you are going to decide what you use the most.
I guess that's why I get to see Maureen.
Is there all of the above, or?
I go for other for that one, yeah. Good. All right.
By
Most
the way,
people.
if your heart rate's over 130, you should come see me after.
Yeah, exactly. Okay. So about 41% of the people, now it's down to 39, 38, should be, about 38% of the people in this room should be seeing me or their physiotherapist. If you use your shins and feet, it is predictive of first episode low back pain. What you should be using is your glutes and your abs. They are your primary support structures. So this is the muscle coordination side of things. So if your biomechanics is good and your muscle coordination is not good, you will go into anaerobic metabolism much quicker, and then everything gets tired and we start to hurt things.
So what about your calves?
They are part of it. So your first responders are the abs and glutes, then it should be your hamstrings, and then it moves. So it's your extensor system is your dominant support. Your extensor system should be working eccentrically to lengthen and support you, so you finish in the calves. But they're not first. The first responders are glutes and abs. Great. All right. So I'd like to recommend that, again, we're busy. Have a seat. So I often say to people, if you're going to do anything, invest in your supporters. Your supporters are your transversus abdominis. It is your essential core postural muscle. Your gluteus maximus is what does supports forward leaning, and your gluteus medius is what does a standing support. So if you're going to do exercises, these are the key guys to invest in. You're going to have a video that's available on an activation for those muscle groups, and that'll be available for you afterwards. And I also have some little tips on how to find your neck posture in another video that you're getting. Simple biomechanical and physiological changes reduce strain. And the reason I have the little angelic emoji there is you don't need to be perfect, okay? Forget about perfect. Make changes when you feel a warning. Do not ignore pain, discomfort, stiffness. It's your warning. It stops you from getting into your attack. Evaluate a high RPE and change if you're more than 4, and evaluate your risk on your MDF that I gave you. Those are your core, which is being used on back care. And thank you to Dr. Horlick and the course organizers.